Hello, everyone, and welcome to the latest webinar in our Key Learnings from COVID-19 series, Pulse Check, Where Things Stand Now, being presented by the Leadership Development Group with Dr. Kent Bottles. I'm Jess Molson, Director of Client Solutions. Just a few quick notes before we get started. Please note that all attendees are automatically on mute for the duration of the webinar. We're expecting a jam-packed presentation today. We're scheduled to end at 1:15. For those of you willing to stay on the line, we're available to take questions until 1:30. Please feel free to submit your queries via the questions box on your GoToWebinar control panel, and our presenter will respond to them during the Q&A period at the end of the webinar. Additionally, please note that the webinar is being recorded. We will provide a link to the recording to all attendees. I will now turn it over to my colleague, Tracy Duberman, President and CEO of the Leadership Development Group, for a brief introduction.
Thank you so much, Jess, and welcome everyone. Good morning, good afternoon, and good evening, depending on where you're calling in from. As many of you know, we are a full-service global talent development consulting firm. We work across the health ecosystem, which we define as providers, payers, and policymakers, as well as any organization that touches the health and wellness of the communities that we all serve. We work across multiple lines of business to support our clients, including assessment and coaching, consulting, and leadership development programs. It also seems fitting for me to quickly mention our on-demand leadership resources, which you can find on our website, tldgroupinc.com. We designed those services this past spring in response to the leadership challenges posed by COVID-19. So I encourage you to explore on your own our new learning content and virtual team and leadership coaching support, which are now available 100% virtually and on demand. So now on to our featured speaker, Dr. Kent Bottles. We welcome him back. Very on-demand faculty member for us, in high demand, I should say. Today, he will be talking about COVID-19 and where things stand. By way of a brief background, Kent is an established physician executive keynote speaker, consultant, and thought leader in healthcare. He has held numerous physician executive positions, including professor and chair of an academic pathology department, President and Chief Knowledge Officer of a biotech startup, and President and CEO of an education and research consortium, Chief Medical Officer of a Midwestern health system, President of an Upper Midwest collaborative of health plans, hospitals, doctors, employers, state government, and patients, and founding Chief Medical Officer of a Big Ten university health plan, giving Kent a unique perspective for being able to view the current challenges of healthcare transformation through multiple lenses. You are a health ecosystem leader. So without further ado, I turn it over to you, Kent.
Thank you so much, Tracy. Here's an agenda that we'll return to every now and then to try to keep us on track. We're going to start with where we are today, August 27th, 2020, in the COVID pandemic. Then talk a little bit about how people think the causes of the US pandemic response failure. Then talk about what you can do when a pandemic hits. One way is to stop the spillover from animals to humans. It turns out that's impossible. So the second way is to stop the spread. And there really aren't that many ways to stop the spread. If you have a vaccine, that helps. We don't have one yet. You can lock down the economy. We tried that sort of, and that didn't work too well. But basically now we're kind of stuck with wearing a mask, staying at least 6 to 10 feet apart from each other, and realizing that it's much easier to get the infection if you're indoors as opposed to outdoors. So then we're going to talk about stopping the spread, early failures of China and the WHO, then the idea that if you can get your level of disease down low enough, you can do testing, contact tracing, and isolation to deal with the inevitable surges that happen during a pandemic. Then we can talk about treatments of COVID-19, and there really aren't that many. There's really sort of three: remdesivir, dexamethasone, and anticoagulants. Then we're going to talk about vaccines. And to talk about vaccines, we have to understand immunology and cytokines, which is pretty complicated, but I think we can deal with it. Then we've got to talk about social media disinformation, because that really has been a problem in terms of us dealing with the pandemic, public health, and then racism and schools. Should you send your kids back to elementary school, high school, or college? And then conclusion. So here we are. Coronavirus disease 2019 is the name of the disease, COVID-19. SARS CoV-2 is the name of the virus. Now, here's the picture of the virus, and these red spikes supposedly look like a corona or a king's crown. This spike protein in red is very important because that's how the virus gets into human cells. That's also the target for most of the vaccines. Now, if you look closely, you can see an orange and a yellow protein. These are important. There's different proteins on the surface of the virus. There's an E protein for envelope, there's an M protein for membrane, and there's a C protein. And those are the site where you can get antigen tests. So we got to talk about that as well. So in the beginning, we kind of thought that the virus was a respiratory disease and that it seemed to kill older people with comorbid conditions, but was relatively mild in younger people. Now we know that it's much more complicated than that. So the overview is that the pandemic started in China when a new coronavirus leaped from bats to humans in Wuhan. And genetics established that it's probably the first human infection in China was in late November 2019. In 60 days, this infection went all around the globe. The first community spread in the United States was diagnosed in January in Washington State. The first person that we think died of the disease was found in a retrospective autopsy in California in February. Now, the United States really squandered its early response, and February and early March we didn't take the virus seriously. So without a centralized federal response, the USA today is a patchwork of many local epidemics and some areas of control. The United States was and is still some places and sometimes unprepared with provider capacity, PPE, ventilators, drugs, testing, contact tracing, and quarantine procedures. Now, if you really think about it, the United States did not fully embrace the two ways that you have to deal with the first part of the virus epidemic. You either can lock down the economy like they did in China and in New Zealand to defeat the virus, or you can leave the economy open like they did in Sweden to try to achieve herd immunity. We kind of did half measures of both, and so we have the worst of both approaches. SARS CoV-2 has been called the Goldilocks virus. As we said, it's not just a respiratory disease. It's not just affecting older people. It's just bad enough in every way. The symptoms can be severe enough to kill, but mild enough to move undetected through a population. It spreads quickly enough to overwhelm hospitals, especially in the New York, New Jersey, and Connecticut area early in the epidemic in the United States, but slowly enough that stats don't spike until it's too late. It's more contagious than the flu, but much less contagious than measles. Now, the R0 is supposed to tell you how infectious a disease is. The R0 for measles is like 12. So everybody who gets measles can infect up to 12 people. Right now, we think that the R0 for the Goldilocks virus, for SARS CoV-2, is about 1 to 1.5. It can cause mild disease, and it does, and some people don't even know they're sick. Or now we know it can cause a severe disease that lingers for months and perhaps for years. And maybe most importantly, one of the biggest problems we have with this is that asymptomatic patients who don't even know they're sick are infectious and can infect other people. Big problem. Let's have the first polling question to see if we're up to speed on the death rate from COVID-19.
Great. So our first polling question is, the true coronavirus death toll in the US is less than that reported in the New York Times, inaccurate due to large amounts of testing, only due to lung disease, only seen in adults, or about 60,000 more than reported. We'll leave this open for a few more seconds.
Let's take a look and see how we did.
So it looks like about 94% of the people on the line said about 60,000 more than what was reported.
And that is correct. So as we said, one of the most important things about COVID-19 is shown here in the blue, that 45%, and some people say up to 60%, of people who get infected from someone that doesn't even know that they're sick. They're either pre-symptomatic or they're people that never have symptoms. About 40% of people are infectious happen when they have symptoms. And it turns out that when we're really worried about about getting infections from surfaces, that's no longer thought to be a major way that this disease is transmitted. So I'm no longer cleaning my groceries with bleach and things as they come in. But this idea that you can get the infection from someone that doesn't even know they're sick is a big problem. Now, the other thing is they're super spreaders. You may recall that in late February of 2020, Biogen had a big leadership conference in Boston. And just recently, in the last week, looking at the genetics of this, it turns out that one conference in Boston in February led to 20,000 cases in Boston. A single Korean churchgoer early in the pandemic caused 5,000 cases. A single Korean clubgoer, and that's a different person than the first one, caused 100 cases after Korea was trying to deal with one of their surges. Famously in Washington State, one infectious choir member got 45 out of 60 church choir members sick. A bartender in the Austrian Alps caused 4,000 cases, and a carnival in Germany caused 1,500 cases. So super spreaders are a big part of the problem. We said at first we thought it was a respiratory disease, kind of like the flu. It was mostly affecting older people. Males were getting more sick than females, but now we know that there's long haulers, and we're starting to learn that there's long-term effects of COVID-19, even for people that don't get hospitalized. Many people still have fatigue and are short of breath months after they no longer have the virus by testing. 87% of people who recovered in Italy still had symptoms 2 months later, and 79% of Germans had heart damage at 2 months after the disease. A 69-country study found 55% of people had heart damage, and half of asymptomatic patients had CT evidence of lung damage. Now, this is not totally surprising because SARS CoV-1, the SARS disease that occurred in early 2000, 20% of those people had lasting lung damage. These long haulers, now we're learning that it's not just a respiratory disease. It turns out that anywhere where we have the receptors that the virus enters the body can be found in the lungs, the heart, the kidney, the brain, the peripheral nervous system, and blood clots. It turns out that these patients often get blood clots, which you know can develop into myocardial infarctions, strokes, or pulmonary emboli. So at Mount Sinai Hospital in New York City, they actually now have a clinic for these long haulers. And this doctor is seeing mostly women. The average age is 44. Now that's lower than the average age of most of the people who got hospitalized in New York City in April and May. These women are formerly fit and very healthy people before they got the disease. And they're showing post-exercise malaise, that they get really, really tired after exercising. They're having months of illness, and interestingly, 2/3 have negative antibody tests, which means that maybe their immune system is not working well. And most of them have autonomic nervous system disturbances like blood pressure problems, heart rate problems. They're having their own support groups and their own research projects. Now, this is a slide from Tomas Puyo, who did some really important things about early in the disease. This is in April. And what you have here is what he calls the hammer and the dance phases of the pandemic. Here you can see this red line are cases going up. And here, Sweden decided not to lock down, not to do social distancing, not to wear masks, not to do hand hygiene, and to just try to achieve herd immunity. And they never did much of anything, and it didn't work out that well. The hammer phase is what you do when you first encounter the virus. And that's what happened in New York City, New Jersey, and Connecticut in April and May. Now, some places like China totally locked down Wuhan to deal with the hammer phase. Other places like South Korea just did testing, contact tracing, and isolation. Other places did masks. Hong Kong did masks, Taiwan did masks. New Zealand did a lockdown, but no mask, and they did well. But this hammer is what happens when you first encounter the virus, because nobody has immunity to the virus. Now, as you go along, you have surges after the initial hammer, and he calls these surges the dance. Now, in the Eastern Asia, they've had several resurgences, and New Zealand, which has done really, really well, just recently had a resurgence of disease after 102 days of no new cases after their lockdown. So Auckland is locked down again after 102 days because they have about 12 new cases. So what you have is the hammer is the way that you deal with the initial response, and the dance is how you deal with the surges that come after the initial response. Now, the problem is you want to get the hammer, you want to get the number of cases way down so you only have double digits cases during the surges, so you can do contact tracing, testing, and isolation to prevent the virus from spreading. The problem for the United States is after the initial surge in the Northeast, we got it down, but we only got it down to 20,000 cases a day. And that makes it really, really hard for us to then be able to do contact tracing, testing, and isolation to control the virus. So until we have a vaccine, we really only have these ways of controlling the spread of the virus: a total lockdown, which really is a problem for the economy, social distancing, the wearing of masks, and hand hygiene. Those are really the only tools that we have. Now, this is why it's been so important to have an effective response to the disease. This is statistics from America, and it shows that the number of deaths in the Northeast by May 3rd were 65,000. However, if we had done social distancing and masks just a week earlier, we would have cut that in half. There would have been only 29,000 deaths. If we had done social distancing and masks 2 weeks earlier, instead of 65,000 deaths, we would have 11,000 deaths. This is why it's so important when you have that exponential growth phase in the beginning of the hammer phase of the pandemic that you jump on it right away. Now, we also now know a lot more about how you get this virus, and we know that there's low risk, medium risk, and high risk activities. We know that you're much more likely to get it if you're inside. You're much more likely to get it in a nightclub or an indoor party or a sports stadium with over 500 people or a church. You know that it's probably less likely, medium risk, if you get a haircut or go to a public pool. And low risk are things like getting takeout food, playing tennis, going to the beach, or walking outside. So we know a lot more about how to control the risk of getting the virus. Now, this is from Professor Akio Iwasaki of Yale. And again, just trying to show you what happens when you get a pandemic with a new virus that nobody has immunity to. If you do nothing at the top here, so you don't have immunization, you don't have a vaccine yet, you don't do social distancing, you don't wear a mask, you do what Sweden did, the infection passes freely among individuals. So over here, these two people in red have the virus. They then spread it to almost everybody they come in contact with. And at the end, you have people that have immunity because they recover from the disease, but you also have many people who die. Those are these people in gray. So you can get to herd immunity if 60, 70, 80% of people have been infected, but you're going to kill a lot of people. Here's what we've been doing in the United States. We don't have a vaccine, but we've been trying to do social distancing, hand hygiene, and mask wearing. If you do this, people get the virus, but then you isolate those individuals to slow the spread of the virus, less people get infected, and fewer people die. If you have a vaccine, and hopefully by early next year we'll have a vaccine, you can see what happens is people get infected in red, but the infection can't pass freely among individuals because many people have been vaccinated, hopefully, and that slows the spread and fewer people die. So that's what happens to a pandemic, whether you do try to achieve herd immunity like Sweden did, try to control it, or have an immunization and a vaccine. So here are the statistics as of today. I just changed these this morning. Over 6 million Americans have tested positive for having had the virus. 183,000 Americans have died. 24 billion people across the globe have been infected, and 830,000 people across the globe are dead. Now, here's just, it's hard to argue that we've done a good job of dealing with the pandemic because the United States has 4% of the world's population, but we have more than 20% of all the cases and more than 20% of all the deaths. So we're not handling this pandemic as well as other countries. Now, it's important to realize that those numbers we just looked at, 183,000 deaths, are clearly a low estimate. That's because of excess death studies. If you look at this for New York City between March and June, the blue line is what usually happens in terms of mortality in an average year. But look, the excess mortality in New York City during the pandemic was 700% above the baseline. So those numbers that we're talking about are really just the deaths and the hospitalizations of confirmed cases. They don't count the uncounted deaths, the chronic illnesses, the people that never got tested. So it's really sort of you only see the tip of the iceberg in terms of the numbers. So the excess death analysis has shown that the US death toll is probably 20% higher, or between 60 and 80,000 more people dead. In the UK, it's 15% higher. In Peru, it's 200% higher. Now, this map just shows that we really are doing poorly in terms of the number of cases per 100,000 people. The United States, Brazil, Peru, Argentina, Iraq, and Spain are not doing as well as other parts of the world. You can see that here. This is a 7-day rolling average of new cases by the number of days since 10 average daily cases first recorded. You can see in the blue that the United States was at a peak of about 65,000 new cases a day, and then that peak is now going down. That's the problems in the Sun Belt: Florida, Texas, Georgia, Arizona, and Southern California going down. And you can see here, this is the first peak over here where we were getting about 30,000 cases a day. That's New York City and all the problems in New York City, New Jersey, and Connecticut. So we're up there with India, and Brazil is not doing as well as the European Union. The European Union is having a surge. You get these surges after you control the virus. And most of the surge right now is in Spain in the European Union. So here's the problem. You can see in Europe, they went up, but then they went down to a level where you could do testing, contact tracing, and isolation to control the surges. In the United States, in the blue, we never got lower than 20,000 cases a day. If you're having 20,000 cases a day, it's impossible to test enough, do enough contact tracing, and isolate people to prevent this resurgence that we saw in the Sun Belt. This is just from 2 days ago. From 2 days ago, Spain had 52 deaths, France 16, Japan 15, Canada 7, the UK 16, and Germany 9. We had 2 days ago 1,290 deaths. Now, our population is about 328 million. The population of the 6 countries up there is 426 million. It shows that we have a lot more deaths than other countries due to COVID-19. So here's the new reported cases by day in the United States, and it shows what we're up against. You can see here in April and May, this is the peak in New York City, where we were at about 35,000 new cases a day. We then, because we did social distancing, wearing masks, and trying to have a lockdown, we were able to stop it going up, and we then had a plateau. We went down a little bit, but the lowest we got was 20,000 cases a day. Not good enough to do testing, contact tracing, and isolation. This here in July and August is the huge bump of cases in Florida, Arizona, Texas, Georgia, and Southern California. You can see now that it got above 60,000 cases a day. It's now going down. And this is where we are today, but we're still at 40,000 cases a day. So we haven't even gotten down to where we were after the peak in New York City. We've got to get this baseline down to 10, 20, 50 cases a day so that we can try to control the spread. Here's new reported deaths per day, 7-day rolling average. Here you can see that we were up to over 2,000 deaths a day when New York City got hit. Now, this was older patients. We didn't really know how to treat the patients. We've gotten better at treatment. We've learned to probably not ventilate people as early as we did. We've learned that if you put people on their stomach in a prone position, they do better. We've learned that if you really are people on ventilators, if you use dexamethasone, you can cut the death rate. So we've learned some things. Here's the peak coming down in terms of deaths, but we're still dying. We're still losing about 1,000 people a day as we speak today. Now, this new surge is the average age of the patients is much lower. And so that's probably why we don't have as many deaths, and we're doing a better job of treating these patients because we know how to do it better. This is 2 weeks ago. So this is average daily cases per 100,000 people in the past weeks. This is 2 weeks ago at the height of the problems in the Sun Belt. South Carolina, Florida, Georgia, Alabama, Mississippi. The dark red, big hotspots in Texas and in Arizona and Southern California. So this is the problem that we have here. A few hotspots in Idaho and Eastern Washington, a few in Iowa at meatpacking plants, but that's 2 weeks ago. So when I say that now it's multifocal, it's lots of local epidemics. You can see spots here, the hotspots. The Northeast, relatively stable, not too much problems. This is today. You can see it looks different. There aren't as many hotspots in South Carolina, Florida, Mississippi. Arizona has done much better now, and Los Angeles has done better. But look at Tennessee, look at Illinois, look at Iowa, look at South Dakota. Now this is where Sturgis was. 400,000 people went to a motorcycle rally in Sturgis, South Dakota, and now those cases are spreading. They're spreading to places like Minnesota, Nebraska, North Dakota, Montana, and Wyoming. So this is the problem. As we get it under control in the Sun Belt, we now have outbreaks all over the place. And what's to stop these outbreaks from spreading even back into the Northeast, where we thought we had it under control, even back into Seattle, where it was under control. So this is why it's scary right now, is that we have lots and lots of local epidemics and some areas like here and here and here that are relatively under control. If you track our COVID-19 response, uncontrolled spread is in the darkest red, trending poorly. Caution warranted, doing okay. Trending better is really only the Northeast is trending better. And here, this is kind of what happened was we did half measures. We locked down the economy for a while, but we reopened too soon. And we didn't deal with the surges. So here you can see in this color of, I guess it's green, we reopened. But here in these brown places, we reopened, but then we had to close up again because we had those surges across the Sun Belt. So some places are on hold now. Some places are pulling back and requiring masks, requiring bars to close down, requiring restaurants to close down. So that's where we are today. So why did the United States fail in its response? Well, two people have looked at this. Ed Yong has written some really good articles in The Atlantic, and David Leonhardt in the New York Times have both looked at recently what they think the reasons are that the United States didn't do as well as other countries in both preventing new cases and in death toll. This is Ed Yong, who's written some really good articles in The Atlantic, David Leonhardt from the New York Times. The Atlantic article quotes Julia Marcus, an infectious disease epidemiologist at Harvard, saying the United States has fundamentally failed in ways that were worse than I ever could have imagined. And they state that it was a sluggish federal response, that we didn't respond early. We kind of lost the months of February and early March. We said it would just go away. We didn't speak with one voice at the federal level. They also point out the chronic underfunding of public health, an inefficient healthcare system, systemic racism, and social media platforms sowing misinformation. This systemic racism is really important because it turns out the death rate and hospitalization rate for people of color, for African Americans, for Hispanics, is much higher than for others. This is Julia Marcus, and we'll see her again. She's an interesting person. Julia is an infectious disease epidemiologist at Harvard, and she has written a lot about how shaming people about wearing masks or not social distancing really doesn't help. She's appeared on the CNN town halls. And she really believes that it's a shame that the public health people haven't been out front trying to help people understand why they should wear a mask, why they shouldn't go to indoors bars, why they shouldn't go to sports events, and that just shaming people won't work. The New York Times article also looks at the unique US failure to deal with the pandemic, and they talked about a lack of effective travel restrictions. We did have a travel restriction from China that was announced on January 31st, but it was rather porous. 8,000 Chinese people entered the US in the first 3 months after the ban, and the system seemed to not screen people coming in the United States. In the first few days, the CDC lost track of 1,600 people coming into the United States. I came into the United States from Southeast Asia in early March and just flew through customs and through the immigration service in San Francisco. No one asked me anything about where I'd been, whether I was sick. Nobody took my temperature. They also think that part of the problem was the confusing advice about masks. Early on, even Dr. Fauci, the NIH expert on coronavirus, said we shouldn't wear a mask in the public. They were trying to save the N95 mask for healthcare workers because we didn't have enough PPE. So we now know that masks are really important to control the spread. We gave confusing advice. They think that there was a misunderstanding of the relationship between the virus and the economy, this idea that you either lock down to control the virus or open up the economy. They also really say the inconsistent messages from the CDC, from the White House task force, from the NIH, and they also mentioned the social media disinformation that confused people about what they should be doing. Now, when you talk about this idea that you either can lock down the economy or you can just not lock down the economy and try to get herd immunity. This is a study from the big pandemic in 1918 of influenza. And it seems to show that you can both try to control the pandemic, but also not ruin your economy. So this, if you look at this axis, these are change in employment. So having more jobs after the pandemic is good. So it's better to be up here. And on this axis, you have mortality. So these are people that dying per 100,000 people. It's bad to be over here. So the best place to be would be right down, would be up here. Lots of jobs bounce back and you don't kill very many people. The green dots are cities that had measures enforced for more days. Measures like wear a mask, social distance. And the red dots are cities that didn't social distance, didn't wear a mask. And you can see that the cities that did more social distancing, more masks, more hygiene, Seattle, Oakland, and Portland, had relatively low mortality rates, but their economies bounced back in 1919 after the pandemic. Those places like Philadelphia, where I live, in the red, or Nashville, they didn't do as well. They had higher mortality rates and worse economic impact. So it looks like most people believe the way to get the economy back is to control the virus. And we have to learn how to live with the virus. So this epidemiologist from the University of Washington has said, as an American, I think there's a lot of good to be said about our libertarian tradition, but this is the consequence: we don't succeed as well as a collective. And Caitlin Rivers, the Johns Hopkins expert, has said, I'm not really sure we ever had a plan or a strategy, or at least it wasn't made public. Here's Dr. Baton from the University of Washington, and here's Dr. Rivers from Johns Hopkins. So it looks like the United States had kind of a half measures. We kind of half shut down the economy. We half tried to social distance, wear a mask, and do hand hygiening, and stay outside instead of indoors. And we got the worst of both worlds. Once you have a pandemic occurring, there's only two ways to deal with it. You can stop the spillover from animals to humans, or you can stop the spread. It turns out that stopping the spillover from the viruses from the animals to humans is practically impossible. The biggest problem is there's too many animal viruses. Climate change has now changed where the animals are, and humans are becoming much more in contact with these animals that have the viruses that can cause pandemics, mostly due to land use changes. So the real experts have said, you're not going to be able to prevent any of these pandemics. There's lots of dangerous viruses that jump from bats to humans. There's 1.6 million potentially zoonotic viruses that can cause harm. We've identified fewer than 1%. You've probably heard of HIV and Hanta and Ebola, maybe Marburg. The problem is that when Peter Daszak went to look at this in rural China, he found that 3% of the population in Wuhan had antibodies to these bat coronaviruses. It turns out that bats are mammals that fly. They're able to coexist with their coronaviruses, and they have lots of coronaviruses that humans have never encountered. As climate change and human land use encroaches on bat environments, we get spillover. Between 1 million and 7 million Chinese have already picked up coronaviruses that you usually don't see in humans. And Dr. Daszak has said these things are spilling over at an incredible rate as part of everyday business in rural China. Now, here's the problem. We spend about $686 billion on the Department of Defense, and we really worry about global terrorism. We spend $47 billion on the NIH and NSF, and yet pandemics have killed many more Americans than any global terrorist attack. So maybe we need to think about pandemics the same way we think of terrorism and fund it better. For example, some people want to spend about $1 billion to identify 70% of these dangerous viruses and maybe get a jump on the next pandemic. There will be another pandemic. This will not be the last one. This is Dr. Peter Daszak, who's done the studies in China about spillover from bats to Chinese rural inhabitants. Unfortunately, the administration has cut off his funding as a way to try to punish China for not sharing information about the virus in a timely manner. So if we can't stop spillover from animals to humans, maybe we can stop the spread. And that's what we're trying to do right now. And if we look at that, early failures, testing, contact tracing, isolation, treatment, vaccines, social media, and public health. So let's take a look at each of these. Clearly, the Chinese were not very helpful. They hid the idea that there was a pandemic going on, and they didn't alert the rest of the country, the rest of the world in time. Now, it turns out that the local authorities in Wuhan withheld information from the national authorities in Beijing. But some people, especially this Dr. Li Wenliang, who's an ophthalmologist that was pressed into action, he went public and tried to warn people that there was a pandemic that could spread throughout the world. The Chinese authorities got angry at him, they severely sanctioned him, and unfortunately and tragically, he then caught the virus. He became very sick, he was intubated, and he died. And it's really, really sad because this man's a hero, and you can see now that there are shrines to him throughout China, and the Chinese have really taken him as a hero who tried to ring the alarm. The WHO also failed to ring the alarm as soon as they probably should have. Now, we need to get to testing. And testing is very, very controversial. You've probably heard that even yesterday, that the CDC changed its recommendation to not test asymptomatic people. And then lots and lots of medical professionals were very upset about that because you can have asymptomatic spread. People who don't have symptoms can spread the disease, and people are questioning the validity of the CDC recommendation. This morning, it looks like the CDC is backtracking, but again, that leads to confusion. When we talk about tests, we're really talking about 3 different kinds of tests. So let's talk about that. There's a PCR test. The PCR test is a polymerase chain reaction test, and that's the one you've been mostly hearing about. That detects the RNA of the virus. The other test is a serology test, and that test looks for antibodies that have been created by someone who has been infected with the virus, and then their immune system, their plasma cells start churning out antibodies, and it looks for antibodies. Now, the sensitivity of the PCR test for the RNA is about 95%. So the false are about 80%. So the false negatives are about 20%, and true positives are about 80%. The specificity of the serology tests is about true negatives are about 95%. So none of these tests are perfect. Now there's another test. So the PCR test looks for the RNA in the virus. the serology test looks for the immune response, the antibody immune response to the infection. But there's another test. Remember I talked to you about those proteins, the M protein, the membrane protein, the E envelope protein, and the S spike protein that are on the surface of the viruses. Those are proteins that you can test for an antigen. And those antigens, and it's really, as of today, Abbott has now said that they have a new antigen test that can be done in the doctor's office and read like a pregnancy test. If one line comes up on the strip, you're negative. If two lines come up, it's positive. This is an inexpensive test. We're not really sure how it's going to be utilized, but most of the testing so far has been this PCR test. Now, the Infectious Disease Society of America has talked about that really we should be doing more tests. And they say that the serology tests for antibodies have been all over the place. Many of these tests are inaccurate. And the Infectious Disease Society is now saying they should only be used for surveys of large populations to see roughly how many people have the disease. According to them, you should only do a serology test for antibodies on an individual patient if a patient has all of the symptoms of COVID-19 and even the X-ray findings, but continues to test negative by PCR test. Then you might want to do a serology test to see if they're having antibodies. The other place that you might want to do a serology test for antibodies is in this multi-system inflammation syndrome seen in children several weeks after they get infected. They would then say you should do a PCR test and an antibody test. You may have heard that we were going to solve the testing problem by using pooled samples. So like do a test on 10 samples together, because then if all of them are negative, you can say they're negative. If any of them are positive, then you have to retest them. That would save testing capacity. It turns out this didn't work because there's too many cases. When we have 45,000 new cases a day, pooled testing has failed to be a logical way to go about it. So here's the problem. We're not doing enough testing. This is as of today. Only 10 states are meeting their testing targets, mostly in the Northeast. 5 states are near their targets, but 35 states are way below the target testing that you would need to have in order to deal with surges that occur during the pandemic. So testing has been a problem since the beginning. You probably have heard that we lost the month of February and early March because the CDC sent out a test that didn't work and it had to be recalled, and it didn't work at all. So we lost 5 weeks. And also Alec Greninger is a MD PhD at the University of Washington. He's the one that was first able to show community spread in the early part of 2020 because he was looking at suspected flu cases near Seattle and created his own SARS Co-V-2 assay and identified the first case on January 19th. Here's the problem. He then said, I should start testing people, and the FDA said no. Took the FDA 43 days to get approval for this testing. So here's Dr. Greninger from the University of Washington. And Pardis Sabita, who's at the Broad Institute of Harvard and MIT, has for years been proposing a surveillance network for tracking new viruses through genetic sequencing. She developed a SARS CoV-2 test in January, but again, it wasn't used in the United States, but she sent it to Nigeria, Sierra Leone, and Senegal. And she says that these African countries had working diagnostic tests long before we had any in the United States. So testing has really been kind of a problem. And this is Pardis Sabiti. She's a very interesting lady. She was born in Iran. She won the Smithsonian American Ingenuity Award for how to treat infectious disease with genetics. She's also the lead singer and bass player in the indie rock band 1,000 Days. If you go to YouTube, you can see her shrieking and howling, singing rock. Interesting lady. So, testing. This is from April, the first part of the epidemic. And here you see the United States, which was testing people, especially in New York and Connecticut and New Jersey, and 20% of the tests were coming back positive. That was because we were overwhelmed with cases and we didn't do enough testing. If you want to do testing correctly, You need to be down here where New Zealand, Australia, South Korea, Hong Kong were. When you do testing, the PCR test, you need to be getting below 3% positives. That means you don't have lots of community spread. When you don't have enough tests, and this is what happened in Europe and the United States, 20% testing, it's a real problem. So that's in April. This is today. In Mississippi today, the rate of positivity of the PCR test for COVID-19 is around 20%. Way too much community spread to be opening schools or anything else. This is New York. New York has gone through its terrible April and May problems, and now it's less than 1% positive. In New York City and New York State, the virus is under control. I just worry that these outbreaks in the Midwest are going to then travel to New York and we'll get a surge in New York. So most states have positive rates that are way too high. We really should have a rate below 3%. In this graph, it shows you that in the light brown, it's 10 to 15%, which is way too high. The dark brown is 15% or higher. You can see Mississippi is 15% or higher, Florida, Texas, Nevada, Idaho. So you really can't control the disease with testing, contact tracing, and then isolation if you have this much community spread. So we should be controlling the surges that occur by testing people and then do contact tracing. We don't have enough contact tracers and we don't have sophisticated contact tracing systems. South Korea, which has used this approach as opposed to shutting down the economy, really has sophisticated contact tracing. So in this case, Bob got infected in South Korea. So someone calls up his family and his friends and his coworkers and identifies people in the blue that need to be tested because they were in contact with Bob when he was infectious. But look at all the green people that we identify by looking at Bob's GPS on his cell phone, by looking at Bob's credit card experience, and by looking at closed circuit TV data. Look at all of these people that they identify in South Korea to test. And once you test all of those people, you then test them because Bob's infected. Many of them are not infected, and so those people are quarantined for 12 to 14 days and then retested. But those that Bob did infect are isolated. And in the Asian countries, this is not go home and stay out of the market. This is you have to go to a government isolation area. I have a family member who lives in Hong Kong, and early in the epidemic, the police knocked on his door. He had been identified as someone who was potentially infected. They made him and took him to a government hotel, and they made him stay 12 days and then retested him. Luckily, he was tested negative. But this is what you can do to do the dance part of the problem is you have enough tests, you do contact tracing, you need to do isolation and quarantine. The problem is we don't do enough testing, as we just saw. We should be doing about 1.4 million tests a day. We're doing it at our peak right now, 800,000. Now, perhaps these new antigen tests that Abbott just got approved, perhaps the saliva test that just got approved, will allow us to do enough testing to do contact tracing and isolation. But that's one way you can control the spread of the disease. The other way is masks. And it's really a shame that we can't get everyone to wear a mask. Here you can see countries that didn't really use masks had many more cases. Countries that did use masks, South Korea, Japan, Singapore, and Hong Kong, had many fewer cases. And most states now are requiring a mandate of a mask, but some aren't. The blue have a mask mandate. But this is why masks are so important. We just said that Spain is having more cases than any place else in Europe. They don't wear masks in Spain. They have 400 deaths per million population. In Taiwan, where they wear masks, it was 0.3 deaths per million population, a big difference. In South Korea, it was 4 deaths per million population. The United States doesn't wear masks as consistently as it should. It's 100 deaths per million population. Big difference between Japan, where it's 2 deaths. So mask wearing is essential to control the spread of the virus if we don't have a vaccine. So, and actually, some people are saying that the economy would do better if we wore a mask. The Economist, a European business journal, has said a single American wearing a mask for one day during the pandemic would avoid a fall in the GDP of $56. The Goldman Sachs analysis has said universal mask mandate could save 5% of GDP compared to a lockdown. So wearing masks makes sense in terms of controlling the virus and also trying to preserve the economy. Let's have polling question number 2 so I can take a sip of water.
All right, polling question number 2. Schools in the U.S. can safely reopen if the percent positive rate of PCR tests is less than or equal to 30%, less than or equal to 10%, less than or equal to 20%, 3%, or 8%. All right, I'll leave this open for a few more seconds. All right. So it looks like we have 78% of people on the line saying that the answer is less than or equal to 3%, with the second highest ranking answer at less than or equal to 8%.
So that's good. So it shows that if you can get people testing being done to try to control the spread of the virus, that if you don't have a lot of community spread, you need to have less than 3%. So in New York City right now, that's what we have. We have less than 1%. So that enables us to try to open up the economy and open up schools, and then just make sure that we're really keeping track of things in order to make sure that if a surge does occur, we have to then kind of like with using a valve, then tighten things up a bit. The other thing is treatment of COVID-19. We've actually learned a lot about the natural history of this disease. It turns out there's different phases. And in phase 1 is the viral infection. Usually lasts a week or so. People have a cough, they have myalgias, they sometimes have a fever. They don't feel well, they're tired. This is due to the viral infection itself. But again, remember, you're infected often before you have any symptoms at all. And it turns out that you're most infectious probably during this viral infection. Phase 2 is when people get really, really sick and get hospitalized. Is thought not to be due to the virus itself. It's due to the immunologic response that your immune system tries to control the virus. And a thing called the cytokine storm, which we'll talk about, and immunologic damage. So this is your inflammation trying to kill the virus is hurting yourself. In phase 3, you get clotting problems. This is where you get pulmonary emboli or strokes or heart attacks. And then phase 4, some people get bacterial superinfections. So it looks like you have to treat these different phases with different treatments, because you have a different treatment for a viral infection, a different treatment for an overactive immune system. Now, we have 750 drugs in phase 2 or phase 3 trials right now. So when it first started, we didn't know what would work. And some people were throwing the kitchen sink at this. We now really only have 3 things that have been proven to be helpful in treating COVID-19. Remdesivir, which is an antiviral, which would be helpful in phase 1. It's not super helpful. It's just barely statistically relevant. Dexamethasone, which would be helpful in phase 2 and phase 3, which is a way to calm down the immune response to the viral infection. And then anticoagulation to deal with the clotting problems. So we don't have a lot of effective treatment, which would be helpful until we get a vaccine. Now, because we don't really know what to do, it's caused a lot of problems in what the New York Times Magazine called the COVID drug wars. You really don't want to give people drugs unless you know that they're going to work. And the way to figure out if they work is to do a double-blind randomized clinical trial where some people get the drug or treatment, some people don't, and you see if it really works. When you don't know, you do experimental treatments with unproven drugs. So we've tried anticoagulants. Famously, we've tried hydroxychloroquine, steroids, and IL-6 antagonists. Now, we've done some trials, and it turns out that hydroxychloroquine doesn't work, although we thought it might work in the beginning. So the fact that you have researchers like Dr. Spiropoulos, and then people taking care of patients like Dr. Zige, you get a lot of problems. During a during a conference at Long Island Jewish Hospital, Dr. Sparopoulos, who's in charge of research, said treating patients at Long Island Jewish outside of clinical trials with anticoagulants was witchcraft. Now, he had just been diagnosed with COVID-19 and his wife was very sick with COVID-19, so he probably didn't choose his words very carefully. But Dr. Langelier, who was taking care of patients in the ICU, was offended and said to have someone tell you that you've been practicing witchcraft is kind of giving no value to the sacrifice I've made in trying to take care of these patients and putting my own life at risk. So you had what they called an intellectual food fight. Infectious disease doctors not wanting steroids to be used. ICU doctors say, let's try steroids. Clinicians versus researchers. This is Dr. Sparopoulos. He has over 160 peer-reviewed articles, is a real scientist. And this is Dr. Langelier, who's a critical care pulmonologist and who's just trying to take care of her patients in the best way she knows how. Well, it turns out that there also is this cytokine mystery. So rheumatologists are used to taking care of patients with immune response problems. They treat lupus and rheumatoid arthritis patients all the time. So Dr. Iris Navarro-Millan was taking care of very sick patients and gave them anakinra, which is a drug that gets rid of cytokine storm, and I'll explain what that is in just a second. There's over 100 cytokines, and cytokines are these small proteins in the blood that are cell signaling proteins. They initiate the inflammatory response to infections. There's over 100 different types of them, and interferon, for example, is a kind of cytokine. Now, Dr. Langelier at UCSF is one of the researchers. He says it's treading in dangerous territory to practice without evidence-based principles. Do no harm. Don't give them anything unless there's a randomized clinical study that shows that it works. So you get this problem between the art and the science of medicine, between the practical physicians taking care of patients and the researchers trying to make sure that we're using evidence-based medicine. So here's Dr. Navarro-Millan. She's a rheumatologist. She's used to dealing with people that have overactive immune responses. Remember, autoimmune diseases like rheumatoid arthritis and lupus are problems where your immune system not really attack your own cells and make you sick. This is Dr. Langelier, who's the researcher, who says, don't ever give a drug unless we have evidence that it works. So here, this is a very complicated slide, don't get worried. This is just showing you there's over 100 of these cytokines. They're called things like IL-6, IL-23. There's lots and lots of them. And what do? They help T cells help B cells, and we're going to explain that in a second. They have a big role in signaling inflammation. Say, hey, there's a bacteria or a virus, let's go and kill it. They have immunity to extracellular parasites. They have antiviral and antibacterial immunity. So these over 100 cytokines are kind of signaling proteins that help organize the immune response that you have. Now, one of the things that we had a controversy about early on was give steroids or don't give steroids. You usually don't give steroids to patients who are infected because steroids can make the infection worse. You give steroids if you're trying to calm down the cytokine storm and the immune response. Well, this Oxford trial, recovery trial in England, was the first to show that in really sick patients, not early disease, but phase 2 and phase 3 patients, that it cut the death rate of people who were on a ventilator by 1/3 and cut the death rate of people on oxygen in the hospital by 1/5. So dexamethasone should be used in severe cases. Now, this is interesting because bats, as we said, are mammals that coexist with their coronaviruses. But bats require an immense amount of energy that create reactive oxygen species that should give you a huge immune response. Turns out that bats are somehow able to turn down their immune response and coexist with their coronavirus. And this turns out to be very important because bats that have a strong interferon initial response to coronavirus don't die. And Stanley Perlman, who's one of the expert cell biologists at the University of Iowa, found that coronavirus infected mice survived if they have a strong early interferon response because it gets rid of the virus, but they die if they lack an early interferon response and then they died from an overproduction and overactive immune system late. So it looks like children who don't get as sick as adults, but can get the disease and can spread the disease, are a little bit like bats, because children have a much higher level of interferon, these special kind of cytokines, and they have much more inflammation than adults, but they don't get as sick. Adults have less interferon. Now, here's the coronavirus again with the red spike proteins and the E and M proteins that the antigen test attacks, and the spike protein is what the vaccine is going to attack. And here's the interferon molecules that can help with the viral phase. Here's Stanley Perlman, the expert from University of Iowa, that has really helped us understand the T cell response and the interferon response to viruses. So it looks like that what we're dealing with is that it's very difficult to deal with the immune system response. We have to kind of balance the aggression of the immune system with restraint and repair. And so we really have trials now of all sorts of drugs listed here that block parts of the cytokines. So this drug blocks this kind of cytokine, this drug blocks this cytokine, this drug blocks IL-6. Now, we've looked at these two and they don't work. So they're not helpful in coronavirus. But even ibuprofen, low-dose radiation, and colchicine are being looked at under clinical trials. The problem is that when clinicians give these drugs experimentally, it kind of messes up the evidence-based medicine clinical trials to decide if it works or not. Because to do a trial, you have to give half the patients the drug and half the patients don't get the drug so that you can see if it really works. Now, that's treatment. So we really only have 3 or 4 treatments right now. Remdesivir, we have dexamethasone for people that are really, really severely sick, and we have anticoagulation. And obviously we have ventilation, putting people on the ventilator. Well, Ed Yong, who we met before, wrote a really good article in the Atlantic trying to explain the immune system response. And the immune system is very complicated. Some people say it's almost as complicated as the human brain. But the immune system is our network of cells and molecules, like cytokines, that protect us from viruses and bacteria and parasites. So what the immune system does is detects a threat. We've got a bacterial or viral infection. It summons help from inflammatory cells, and it counterattacks. Now, there's 2 kinds of immune system response. And the reason we're going into this is that the immune system is how vaccines work. So the innate immune response is quick, primitive, and generic. It's one shared with most animals. It doesn't have memory. It just says something's going on and we should attack it. The adaptive immune response is slower, but it's much more precise. It's long-lasting and has memory. Okay, so the immune system itself, as we've found, causes inflammation and can damage the body as well as destroy the pathogen. That's that balance we're talking about. You need to have enough immune system response to kill the pathogen, but not so much that it hurts yourself. And it turns out that we're hearing that the long haulers of COVID-19 are mostly being hurt by their own immune response. So there's different groups of cells and molecules for 3 different groups of pathogens. Viruses and microbes that invade cells have a certain immune response. Bacteria and fungi that stay outside cells, they have different molecules that come in to try to kill them. And parasitic worms have a whole different immune response. What's weird about COVID-19 is all 3 of these responses seem to be activated. So a basic scientist studying the immune response has said the immune system almost seems confused as to what it's supposed to be making. It's doing all sorts of things that make no sense. So the immune response has T cells. Now, T cells are just lymphocytes. These are red cells here. This is a lymphocyte. I can't tell you it's a T cell just by looking at it. You have to look at the receptors on it. But these are T cell lymphocytes, and that's part of the immune response. And that's a very important part of the immune response. Now, T cells are important for 2 different reasons. One is they can become killer T cells that directly attack the pathogen. And the second reason is that they coordinate and recruit other white blood cells to specific pathogens like bacteria, fungi, or viruses. So they kind of coordinate the attack. This is an electron microscopy of a T cell showing the different receptors. And this is a plasma cell. So a plasma cell is a kind of lymphocyte. It's a B lymphocyte, and it's the one that makes antibodies. And antibodies is what you want to get in a vaccine. Now, antibodies are Y-shaped proteins that these B lymphocytes called plasma cells make, and the vaccines would make your plasma cells make antibodies. The antibodies attach to the pathogen surface to kill or prevent the pathogen from entering cells. The antibodies also signal the immune system to activate via T cells and all these cytokines to clear the pathogen and protect the body. So here's a cartoon of an antibody looking like a Y. Here is that virus, the COVID-19 virus, with its S spike protein that in other cartoons we saw as red. So this is the area that's going to be attacked by the antibodies from the vaccine. Now, we don't know much about antibody response, but just recently a paper was published that 122 fishermen went out on a boat from Seattle. Almost everybody got COVID-19. It had to come back to Seattle for hospitalization, but 3 crew members had antibodies at the beginning of the trip. They didn't get sick. That's a good sign. It shows that perhaps the antibodies protected these 3 crew members from getting from getting the disease. So we know that spike protein is a good coronavirus target, and it looks like we have different approaches to making a vaccine. The Chinese are trying to do the old-fashioned inactivated virus vaccine. So you take the virus, you inactivate it, and you create an immune response. We're also trying more advanced gene-based vaccines, where there's a vector of a benign virus, like an adenovirus or a chimp cold virus, that is used to get the vaccine into the cells. And that's the J&J and Oxford vaccines you've heard about. And then Moderna is making a viral gene snippet inoculum. Now, these gene-based vaccines we think are going to work. Theoretically, they should work. We've never had an approved gene-based vaccine, so hold your breath. Here is the antibody produced by your plasma cells, either because you've been infected or because you've gotten a vaccine. It attaches to the spike protein of the coronavirus. Here's the RNA inside the virus. This is Susan Weiss, who's a professor at Penn and the other big expert in the cell biology who identified the spike protein as the best place to attack with a vaccine. Now, in the past, vaccines have taken 4 years to develop. And the other thing we got to be really careful about is that in the past, some vaccine candidates for SARS, HIV, and dengue fever have triggered an antibody-dependent enhancement, which made the recipients more likely to get infected and get sick. It didn't protect patients, it made it worse. So we certainly don't want that to happen. We still don't have an HIV vaccine, and it's going to be really hard to produce enough doses. Because remember, only about 10% of Americans have been infected with the virus. So over 300 million Americans need to be vaccinated, and everybody in the world needs to be vaccinated. So vaccines have to go through phase 1 safety trials, phase 2 safety and beneficial trial, and phase 3 trials. And we don't even know if the immunity will last that long. So here we are, the tracker. There's over 135 vaccines in preclinical. 2 have been approved, 1 in China, 1 in Russia, but we're worried that they really haven't been tested well enough. 8 vaccines in America and in Europe are in phase 3 trials, and we're hoping that they will be available by early next year. This is a problem. What if we have a safe vaccine, but people won't take it? This is 87% of people in China said they'd take it. Only 55% of people in Russia said they'd take it. Only 68% in America. If lots of people don't take the vaccine, then we're not going to get to herd immunity, and the virus will still spread throughout the population. Okay, social media has been a big problem. In every outbreak from Zika to Ebola, conspiratorial communities immediately spread the content that it's all caused by the government, pharmaceutical companies, or Bill Gates. This is an expert on social media. On social media now, we have a lot of misinformation about George Soros, about 5G, about bioweapons. This terrible, unscientific webinar called Plandemic said that the goal was to take down Anthony Fauci because he created the pandemic. And 8 million people watched this unscientific webinar in 1 week. This is the expert who, Judy Durinstis, who's DiResta, who has said that we really have a problem with misinformation. This is Dr. Judy Mikovits, who is the person saying that the virus was caused by Anthony Fauci. That's not true. We now have ER doctors being accused of profiting from naming the virus as a cause of death on certificate. We've had internists treating patients who drank bleach. We've got Facebook trying to remove misleading posts. And this is what really got me. I just found this. Health misinformation spreading networks had 3.8 billion views on Facebook last year. In April alone, there were 460 million views of misinformation. And the content from bad healthcare websites had 4 times as many views as legitimate websites such as the WHO, the CDC, or the Mayo Clinic. Polling question 3.
Okay, polling question 3. Public health support in the US has been characterized by only 3% to public health of 3.6 trillion overall spend, budget cuts since 2008, outdated computer systems and data collection, inadequate pandemic drills, or all of the above. Give everyone a few more seconds to respond. Okay. All right, looks like almost everyone on the line said all of the above.
Correct. It's a very smart group. We have a problem. We haven't been spending enough money on public health. Only 3% of our $3.6 trillion has gone to public health. We've lost jobs. We've had budget cuts. We have outdated computer systems. And this is just terrible. This is why there's a lot of mistrust of the CDC, of the FDA. We haven't invested enough money in these. And the fact that we're not having the CDC be able to give us trusted information is really causing a lot of problems. And we have here, in most epidemics, the CDC is the leading expert. The head of the Harvard Global Health Institute has said the CDC is no longer the reliable go-to place. Here's an agency that's been waiting its entire existence for this pandemic moment. Then they flub it, former FDA official. The lab director of the Minnesota Health Department said the silence from the CDC is deafening what's going on. Not clear what's going on, but the CDC and the FDA are really under a lot of criticism by a lot of health experts. Julia Marcus, who we've already met, and here's another picture of her showing she's much more fun than I am because she has purple hair, has really emphasized that the CDC has experts that could help us get people to wear masks, get people to social distance, but shaming them doesn't work. And we now have LA shutting off power and water to party houses and Chicago barricading beaches. She says that's not the way to do it. That what you want to do is do what Oakland did, have some streets without cars where there's bars that will give you drinks. Toronto loosened the rules to allow beach-themed beer gardens. You got to give people some way to associate with other people or they go crazy. This is the public health expert in British Columbia who has said, I strongly believe we need to be kind to each other and to stay calm, even in the face of fear and anxiety. So this public health shaming and shutting down people's power because they have parties is probably not going to work. So we need to talk about racism. Here's the age-adjusted COVID-19 hospitalization rates. It's 53 per 100,000 for whites, 247 for blacks, 243 for Hispanics, and 281 for American Indian. Here is the COVID-19 mortality rates. 36 per 100,000 for whites, 80 for African Americans, 46 for Hispanics. This disease is hitting the people of color much more than white people. We used to say this was all due to low socioeconomic status and comorbidities. Now we realize it's probably systemic racism. And there's lots and lots of evidence that systemic racism does occur. And systemic racism means there's structural things which, even if every single person wasn't racist, there still would be systemic racism. And we now know, just to give you one example, mortality rates for babies born to black mothers with masters or doctoral degrees is far worse than mortality rate for babies born to white mothers with less than an 8th grade education. So why is this? Well, it looks like it's increased activation of the stress response. If you have lots and lots of steroids in your body because you see a snake and you're trying to get out of danger, that's a good stress response. If you have chronic stress response because of racism, that's not good. So it shows that Black women are 243 times more likely to die from pregnancy than a white woman. So there is structural racism. We know what we should do about it. Maybe now we'll finally face it, but we haven't really faced it very much. It's a huge problem. Let's talk about schools for a second and then open it up for questions. By April 2020, 89% of the world's children had shut down, no schools. Some countries have successfully reopened. Some countries have failed. Israel failed miserably. When they reopened their schools, they had a huge spike in cases. It looks like now colleges are reopening with mixed success. And as of today, 6% of colleges will reopen online only, 27% primarily online, 15% hybrid, 20% primarily in person, 2.5% solely in person, 6% doing something else, and 24% don't know what they're doing. You probably saw that Notre Dame, University of North Carolina, tried to have in-person classes. They brought people back. They had so much spread of COVID-19, they had to close down the in-person classes and go to online classes because it didn't work. For elementary school and high school, the default should be reopened. Why? Because children need to go to school. If they don't go to school, there's academic regression. Many kids don't have access to meals except at school. There's reduced identification of childhood neglect and abuse. There's reduced socialization, and adults are going to hurt the economy if they can't go to work because their kids are at home and can't go to school. You can successfully reopen schools. However, you have to have a low baseline of community spread, less than 3%. If you have more than 5%, you really can't open schools because you have too much COVID in the community. You have to have mandatory contact tracing of the positive cases. You have to have physical distancing. You probably should have staggered schedules. You have to clean the classrooms. You have to have kids wear a mask when they're inside. You have to do as much instruction outside as you can. You have to reduce the class size, and you probably should start with younger children because it looks like a South Korea study said kids 10 to 20 spread the virus just as much as adults. Kids who are infants to 10 years old don't spread the virus as much. We still don't know everything about the spread of the virus within children. All right, so let's skip this and go to how to be successful. If I were in charge today, I would say we need a clear, consistent message of a federal strategy and plan. We should have the Defense Production Act to get enough PPE and testing so every place in America has less than 3% positive tests. We should let scientists lead the communication about how to deal with it. We should have a national mask, hand hygiene, and social distancing policy. Anybody who's at risk, age 65 or above, or people with comorbidity should stay at home. We should open gradually and with adjustments as the surge comes up, we should dial back. And we have to manage risk responsibly, realizing that it's much easier to get the virus spread indoors in big groups than outdoors. And we have to recognize that lots of other countries did better with no universal playbook. China and South Korea, Japan used masks. New Zealand didn't use masks, they locked down. Singapore, Japan, and Germany had scientific leaders. Hong Kong didn't have a government response. They had a grassroots movement. China locked down, South Korea did not lock down. Here's some good references, and let's open it up for questions.
Okay, great. Wonderful job, Kent. And I have some questions for you.
Great.
So, great. Okay, first question. Can you recommend some resources for us non-bioscience people, which you just did? That was a very quick response. And also, I'd like to know how the hot topic of the microbiome factors into the immune system and its over-response as an autoimmune disease.
We don't know.
How the hot topic.
There's a lot of scientific evidence going on now. We're not really clear how the immune response works to COVID-19, and certainly the microbiome could be involved, but we don't know. There was just a study that came out that seemed to show why men get sicker and die more than women. It looked like that their immune response, especially their T cell response, was not as good as women. That women, even when they're over 65, have a better immune response than men. So perhaps the immune response in different people is different. That may be genetic. We just don't know yet.
Okay. Going back to the earlier part of your presentation when you talked about the drug treatment trials, do you know if
Yes.
anyone in those phases were asymptomatic when they did the studies?
I don't know, but basically most of the people would be symptomatic in the drug trials, or else they wouldn't have been enrolled, I don't think.
Okay. Would you send your elementary school age children to school?
I would send elementary school age children to school if the community spread was less than 3% on PCR testing, if the school had actually put a lot of effort into distancing, having most of the instruction outside, making sure the kids wear masks. There are ways to do it. I think it's going to cost a lot of money and a lot of planning. Interestingly enough, Sanjay Gupta, the CNN expert who's a neurosurgeon, has some teenage daughters in Atlanta, which has too much community spread. His children go to a very fancy private school that's done a lot of work. He's not sending his kids back to school because the positivity rate of the testing is way above 3%. Interestingly enough, it can be done. We just had a study came out of some summer camps in Maine that had over 1,000 people successfully go to summer camp in Maine, but they had a multi-level of testing, of temperature checks, of small pods, of people wearing masks. Only 3 people out of 1,000 were infected, and they were easily tested and then isolated. On the other hand, a camp in Georgia over the summer was a disaster. Out of 597 campers and staff, 44% had spread of the disease, and they had to shut down, and they did not wear masks. So I would send my kid back to school if I was in an area with little community spread, and if I was sure the school was taking into account all of the safety measures they should take.
Great, thank you. Next question. Even if you are asymptomatic, how soon after you have been exposed to somebody with COVID-19 should you be tested?
Interesting. The new antigen test that just got approved today is only good in people with symptoms. So if you are identified as someone who's been in contact with someone who tested positive, what they're doing is testing you and then making you isolate for 12 to 14 days and then retesting you with the PCR test. So you certainly could be infected and have a low level of virus early on and test negative. So there's a 20% people that have infection test negative early on. So that's why they isolate these people for 12 to 14 days.
Mm-hmm. Are we going to get worse during the COVID-19 pandemic in the winter in the US?
We hope not. If we could get the bench line down to 100, 1,000 cases a day. Remember, right now we're at 45,000 cases a day. We've really got to get it down by having everybody socially distance, hand wash, and wear a mask. We could probably do okay. The problem is in the winter, we may get hit with influenza and COVID-19 at the same time. I'm very worried, and actually the head of the CDC has said he's very worried this might be the worst winter on record, when we get hit both with influenza and coronavirus at the same time. So please, everybody get an influenza vaccine. And if you're over 65, get the super duper one for elderly people. And as soon as we have the FDA, hopefully, do a good job of saying the vaccine is safe, we should all get vaccinated. Although it's going to be interesting to see how quickly the vaccine can be distributed. So this winter, I'm very worried that we're going to have another surge. Remember in 1918, in the influenza, there were 3 surges of death, not just one. So we've had 2 surges now, and I'm really worried about having us another surge unless we can get that baseline down way farther than it is. As of today, 45,000 new Americans get infected every day.
So how can we be affirmed that the data is correct? Who do we believe? Fauci, CDC director? There's too much. It's very confusing.
If you look at my references, which are up here, Scott Gottlieb, who's a conservative who ran the FDA under Trump, is a very reputable guy who's science-driven. Andy Slavic, who ran CMS under Obama, is really good. And Eric Topol is brilliant. So I trust Anthony Fauci. I trust Ed Yong. I trust the people that I've listed here on the references. These are very scientifically driven people. It's a shame that there is some people who are experts who are questioning the FDA and the CDC. And part of that is the FDA and CDC's fault. The head of the FDA just a week ago really made a mistake in talking about convalescent plasma. That's a way to take plasma, which has antibodies from people who have recovered from the disease, and give it to patients who have the disease. We don't know if it works. We haven't done a clinical trial. Over 70,000 people have received convalescent plasma. We think it might work. We don't know. But the head of the FDA in a press conference said it saved 35% of people's lives, and that just wasn't right. He's now retracted that, but it doesn't help when we keep getting mixed messages out of the White House Task Force, the FDA, the CDC, the governors, the mayors. It's really a problem that we need to have one consistent message. I trust the people listed on these references. They're letting science be the guide, and that's why we should have scientists and epidemiologists telling us what to do.
Mm-hmm. So how do we get people to adopt the strategy against COVID-19?
Well, the CDC and immunologists and epidemiologists have learned a lot about how to get people to do things. Shaming doesn't work. Arresting people doesn't work. Julia Marcus, which is listed here, is an epidemiologist at Harvard. She's written some really good articles about how in HIV, telling people to just abstain doesn't work. You have to give people strategies to use that slide I showed you about titrating your risk. I myself have gone out a little bit to get groceries. I'm over 65, but I'm very careful. I always wear a mask when I go out. I stay 10 feet away from anybody I can. If there's lots of people in the store, I don't go in. So we have, and then like she said, in Oakland, California, they've opened up some streets where people can walk and stay safe away from each other, but get drinks and drink the drinks outside. You shouldn't get mad at people for going to a beach if they socially distance. So we can't just say lockdown forever. People won't do it. We can't just say to college students, don't drink. College students' brains aren't developed enough to do this. And so we need to really learn from what we've learned that abstinence doesn't really work in sexually transmitted diseases. But there are ways to get people to at least learn what's low risk, what's medium risk, and what's high risk. I would not go on an airplane today. I would certainly not go to a sporting event with over 500 people. You're going to catch the disease when you're in an indoor environment with people screaming or singing or praying loudly, and you're with lots of people that are close together. So you can actually, if you're smart, wear a mask everywhere and not be totally locked down, but be able to stay safe enough. But remember, only 10% have been infected so far. Till we have a vaccine, and we don't know when we're going to have a vaccine, there's 300 million Americans that are at high risk for contracting this virus.
Yes. So we are at the very end. So I'm going to wrap up and let everyone know. First of all, thank you, Kent. That was a fantastic presentation. So thoughtful and engaging. I want everyone to know that we're going to be sending out a survey right after this presentation, and then we're also going to send out a follow-up email that will have the webinar's recording and the written responses of the questions posed to Kent and his answers. We're also going to post Kent's webinar to our COVID-19 Leadership Resources Center on our website. And finally, if you're interested in having Kent come to speak at your organization, please contact us at info@tldgroupinc.com. Thank you. Thank you, Kent. Greatly appreciate you always. All right. Take care, everyone.